Hi, Dr. Madan. I'm Sanjay Maurya from OneRx. Sir, we wanted to know how are you using OneRx in your daily clinical workflow?
Yeah, it's just good using whenever I have any doubt.
Okay. So, what kind of queries do you usually ask? Just wanted to learn from you.
So any if I'm not getting any evidence to support my judgment, then I search RX.
All right.
Awesome,
That
Doctor.
is good. Yeah. Yeah. Dr. Tulika, if I may invite you to share how are you using OneRx and where do you find it useful?
Yeah, it's good. I think the best part regarding this app is that you give all the links. So if
Mm-hmm.
I have to go through the references, I can click on that immediately and I can still go back to the previous page as well. So it's not like you have opened a page and then you have to continue or you lost the previous track. So that thing I really like about it.
Understood. And ma'am, are you using patient feature? We have a patient feature as well.
No, I've not yet explored it.
Acha, theek hai. So at the end of this webinar, I will also request Dr. Haneesh to showcase the patient feature and how it is useful for clinical use.
Okay.
Over to you, Dr. Haneesh. I'm going to remind the doctors to join in.
Okay.
Yeah.
And before we start, doctors, I have a quick question. Have all of you installed the OneRx app? If no, you can install in this gap. It is available both Play Store as well as App Store. Because this session will be interactive and practical, so that with the case we can do the live demo with your app. Thank you for joining us with OneRx, Dr. Manjeet.
Hi, Dr. Haneesh. I think we have the room now. We can start.
Yeah. Thank you for joining Thursdays with OneRx. I'm Dr. Haneesh. I'm working with OneRx for oncology therapy area. So I'll be moderating today's discussion. So think of this as a live clinical discussion, and where we will explore the case together and see how evidence, guidelines, specialist perspective comes together for real world evidence. I'll share my screen now. So before starting, we will show who we are and what we are doing now. And I'll play a video now. So we are in OneRx, a medical evidence platform for doctors. At the moment, used by 800 plus oncology daily across India's top cancer center for evidence summary. So what OneRx gives to you at the point of care, second opinion, trial comparisons, cost and schemes, drug intelligence, and deep focus on oncology, medically trusted data sources we have built from NCCN, ESMO, ASCO, PubMed, Lancet, OncoLive, among others, and clinically validated with precision AI study. So we have done 93.3% clinical decision impact, 97% accuracy, and zero unsafe recommendation in stage one of study. And data privacy is important. So we have certified HIPAA, SOC 2, DPDP compliant, and ISO 27001 certified. So, as oncologists, we all know that finding information is not a big challenge anymore. So, before we begin, one quick poll. So, when managing a complex head and neck cancer patient, what consumes the most time? Option A, finding the latest evidence. Option B, comparing guideline recommendations. Option C, assessing Indian availability and cost. And option D, reaching a treatment decision. You can drop A, B, C, or D in the chat. Let's see what the room lands. So as I have highlighted earlier, the finding the information is not a big challenge anymore. But the real challenge is bringing together the right information, right time for the right patient. And the head and neck cancer is great example for that. So for any oncology body part, for oncologists, he'll be getting three important questions in any tumor board. What does NCCN or other guidelines actually recommend today? What is the evidence after progression on current therapy? What options are realistic available in India? So in general, most of us spend 15 to 30 minutes searching guidelines, papers, Indian specific access information for every complex metastatic case. So today, our job here is we will see if our platform OneRx can answer all three in under a minute or not. And from question to evidence to decision. So in general, typical workflow. So a patient progresses, a doctor will start searching the options. First, searching NCCN guidelines, searching evidence trials, searching Indian availability, discussing options. Generally takes 20 to 30 minutes of time. So what everything comes at one place in less than 1 minute. So here, OneRx is not replacing any clinical judgment. It brings the latest evidence to the decision point. So let's, before going to the any slides, let's go for the direct case, head and neck cancer. So we got a case from renowned hospital, a patient of age 58-year male having former smoker. He quit 15 years ago, but he have a smoking history of 10 pack a year. And his chief complaints: painless right sided neck, swelling for 2 months, no dysphagia, odinophagia, voice change, weight loss, or other constitutional symptoms. What in clinical examination confirmed? A non-tender 3 centimeter right level 2 cervical lymph node and small lesion identified in the right tonsil on oropharyngeal examination. And in diagnostic workup, so in biopsy got squamous cell carcinoma and T16 positive, which is HPV associated, and MRI status got. So in right tonsillar primary lesion shows 2.5 centimeters and 3 centimeter single ipsilateral level 2 lymph node and no radiological evidence of extranodal extension. And CT scan shows no distant metastasis. And as per AJCC 8th edition, the patient is stage 1 HPV associated oropharyngeal carcinoma. So here a question we have for a surgical oncologist. So whether I have to do surgery for the first treatment or I have to go for the radiation for the better option. So what I will do, I'll take the case and I'll put it in the app and let's see the options what available evidences. So here we have frame on algorithm here. Whenever we ask a question, so it picks from the landmark trials, that is NCCN, ESMO, ASCO, and PubMed articles. So we will get the right evidence pattern for every answer in a structured way. So the surgical oncologist question, should surgery be the first treatment or would radiation be the better option? So what evidence says for this question? So here NCCN guideline version to 2026 supports both options are guideline endorsed. So let us see here. NCCN, what NCCN guidelines is. NCCN version 2 2026 supports either approach, and here it supports both transoral surgery with a neck dissection with risk adapted adjuvant therapy and also definite radiotherapy, which are guideline concurred. And let us know why surgery is preferred in this case. So this transoral resection of the primary tumor with ipsilateral neck dissection is recommended for T1 to T2 limited node positive P16 positive OPS squamous cell carcinoma. And the biggest advantages of this surgery first enables pathology driven adjuvant de-escalation. This is probably the most important surgical takeaway. And we can see the biopsy and pathological confirmation, right tonsil core or incisional biopsy showing squamous cell carcinoma P16 positive by IHC, which is greater than or equal to 70% nuclear plus cytoplasmic staining moderate to strong intensity. And the treatment decision, surgery versus radiation therapy, what guideline recommends. So NCCN version 2 2026 status, transoral surgery TORS plus neck dissection recommended option category 2A, and in radiation therapy recommended option category 1 for concurrent chemotherapy in higher nodal burden, and adjuvant therapy only if ENE positive or positive margins, cisplatin plus RT. And we also got a de-escalation potential and QL advantage and Indian assesses. Limited torch center, this obviously we have very less adaptability for all the hospitals. So this is what the patient prognostic profile. Former smoker quit 15 years ago, having 10 pack year history, and what favorable decisions making for the patient, and what FDA and CDSCO regulatory context gives. And this is the monitoring section we have to do for the patient. For the post-treatment, the clinical examination, MRI or PET-CT at 8 to 12 weeks, post-RT or 6 to 8 weeks post-surgery, and PTCT preferred if residual nodal disease suspected. And also have to do plasma, EBV, DNA not applicable, and thyroid function test for every 6 to 12 months, and surveillance clinical examination every 1 to 3 months. So I'll open for the discussion if any surgical oncologist there in the audience, what evidence supports and what's in your practice in your for your patients. If no, we can go for another question. What radiation oncologists have question for this query? So
So,
for the radiation, yes.
so Dr. Nish, what are the other features of this product? Like what all does it, can it do? How can it help us?
Yes. So we have other futures, that is the patient future. So in this My Patient Future, you can upload your patient name, for example, Raju, and after adding, we have add files. So we can upload, for example, NGS reports, CBC, PET CT scan, MRI report, whatever the reports we have, we can upload all the files here. So after uploading the file, if we submit, it will give the AI summary, evidence-based AI summary. Based on this AI summary, we can ask the further questions like what is the first line recommended regimen for this cancer, or what is the diagnostic approach, or else any monitoring sections we want, the questions as per need.
Okay, okay, thank you.
Yeah. And if any questions
We'll give it
from
deep dive.
yes, doctor. Okay, we'll go for the another question. So in radiation oncologists have the question, should be radiation be given alone or should radiation be combined with the chemotherapy? So what I will do, I'll take this follow-up question and I'll ask in the chat box. So I need to highlight one of the feature here. There are the crores of articles in across the PubMed. For example, in ASCO 2026 recently happened conference at Chicago. So many articles have published and they have highlighted and new drugs got approved. So we need to get evidence in the good hierarchy manner. So what we made here is the evidence hierarchy. So whenever if you ask the question, it first picks from the meta-analysis, then it'll go for the randomized control and control, then cohort studies, case studies. Based on these parameters, we will get the reference links as well as the citations for supporting the answer. So here I have asked the question, radiation oncologist question, should be radiation be given alone or should radiation be combined with the chemotherapy? So for the stage 1 HPV positive squamous cell carcinoma with N1 nodal disease, the concurrent chemoradiation remains the standard of care. You can see here a concurrent chemoradiation is the standard of care. And why not radiation alone? So N1 nodal involvement carries a sufficient loco-regional risk to warrant concurrent systemic therapy. And we need to know what NCCN guidelines says. So here NCCN guidelines reserves the definitive radiation alone primarily for T1 to T2 NO disease. And this N1 disease generally requires concurrent chemotherapy. And what evidence supporting the chemotherapy? So here we can see here the key trial evidence RTOG 1016 phase 3 clinical trial cisplatin plus RT versus cetuximab plus RT in P16 positive in squamous cell carcinoma. So here we got the survival benefit 84.6 percentage and confirming the cisplatin superiority. And when we had to do the de-escalation context, we got RT dose reduction to 50 NCCN category 2B. It is considered for the post-surgery in ECOG status 33-111 and intermediate risk criteria less than or equal to 4 ipsilateral positive nodes. And what is the patient specific considerations? So like smoking history less than or equal to 10 pack years and he have quit 10-15 years ago. This does not downgrade the prognosis significantly. And what EGFR? Here, if EGFR less than 50 ml per minute, we have to switch for the carboplatin. What this is what NCCN guidelines recommends. And monitoring section, because most of the oncologists have given feedback for us. Monitoring section will be the disappeared one for the doctors in clinical practice sometimes. So for this, we have added the monitoring section. Whenever if you ask a question, the monitoring will be highlighted if the question hits drug regimen or question related to treatment. So for this patient during CRT, CBC weekly and renal function and electrolytes before each cisplatin cycle have to do. And we have to do assessment test PTCD at 12 weeks post CRT and neck dissection only if PET is positive residual nodal disease. So overall, we got the evidence supporting for the radiation. And if you have any follow-up questions for supporting the answer, you can drop in the chat box. We can ask to the platform and we can see what evidence says for this answer. Any questions from the from the users?
Hi, doctors. Let me pick this up. So, Dr. Haneesh, thank you so much for doing this. There are a couple of very strong elements that clinicians find in OneRx. The first one that I'd like to take you to is this section called Discover. Dr. Haneesh, can we go to Discover?
Yes.
Okay. Now, what happens in Discover is we've integrated with almost all the major sites, including, for example, FDA. Let's come to oncology specifically, Dr. Haneesh, since this is an oncology panel, right? So what you will be able to see over here or get over here are any molecules, any changes that FDA does almost the next day. Okay. And as it comes over here, the answers can also, or that particular element can start factoring into your line of therapy the moment you start querying for it. So if FDA makes any drug changes, if FDA approves any new drug, for example, or any new regime, for example, starts coming into your ask section. So let's come to ask now, Dr. Haneesh.
Yes.
Okay. You can put in your entire scenario and it can give you an answer which is in accordance with the latest NCCN guideline, the latest FDA guidelines, and all the other sources that we typically rely on for our therapy. So you can see what it does is it's compressing a lot of time that you would take on just research down to a fraction of a second and a couple of clicks. Um, Patient is the last feature of the platform. So let's come to patient. Ask typically used for ad hoc queries, etc. But if there is a patient with you and you want to track their history over a longer period of time, practicing clinicians start using this. Okay. Uh, just yesterday, I was another doctor, and we had a 50, 60-page long report. He would upload it and at the very beginning get the most important elements of the report that the doctor has to focus on, then the summary, and then the immediate next step. So they don't have to go line by line on everything which is out there. So if you upload the second report, which is the same one, it will be able to share and tell you about the improvements in that particular patient. So overall, what it is doing is number one, it is giving you the latest information. It's aggregating all the evidence summary from all the sites that we rely upon and bringing it to you at in just a fraction of the time, like a minute or so at most. So this is what OneRx is all about. But I'm going to pause and I'd love to hear from you. What do you think can help you? We're very curious about it. In our team is a couple of doctors, both clinicians as well as full-time with us, AI engineers and other developers. What can help you? I'm going to pause now and just invite your responses. What can help you? What would you like to see more of? So Dr. Madan, Ayushi, um, Dr. Shankhi, Dr. Sonima, I hope I'm pronouncing your names right, Dr. Anusha, Dr. Mamta, Dr. Sankalp, Ritik. What would you like to see more of that can help you in your everyday clinical practice? If you're speaking, you're probably on mute, so just unmute yourself if you're speaking. Okay. That's perfectly all right. Should you have any suggestions, please do message us. Please do ping us. We'll only be too happy to work this out with you. Let me drop my email at the chat window so that you all have it with you. This is my direct email, and I will be very happy to interact with you. Let me also drop in my WhatsApp number. Please
Good,
feel free to message me.
good evening, Mr. Vivek.
Good evening, sir.
Hi, I'm Dr. Manjeet. I'm a
Dr.
medical
Manjeet.
oncologist. So, can it summarize if we upload some documents and very concise summary to hand it over to patient, something like that, and if we can print that, that will be quite useful.
Okay. So,
Apart from that,
sorry, sir. Please go ahead.
apart from that, if it can integrate apart from these guidelines, if there are any good review articles by some experts, so we
Hmm.
might get some other insights from that,
Hmm.
uh, just for the data collection or recommendations.
Got it. Got it. Got it. Dr. Manjeet, I think so. On the first part, which is the summary and print for the patient, we'll definitely work upon it. We are summarizing it at the moment for doctors. So the nature of literature is very medical oriented. We'll just have to look at how to do it for the
That is
patient.
also fine. Sorry to interrupt. Basically, this is if the patient is going to so some other doctor, our colleague. So, and if we can add something in that, some paragraph, our recommendations, and sometimes it happens. The
Yes.
patient goes to some other doctor.
Yes.
So it will be very easy for him or her to go through and what was our uh, basic thought process. So we can add that and then we can give it. That will be helpful
Okay.
for
So
us.
you're saying
What
that
I
if we
think.
can add some notes or something which another doctor can
Yeah.
read as they are looking or
Yes.
attending to a patient, correct?
Correct. Correct.
So, like, patient goes to a medical oncologist, let's say to a surgical or to a radiation oncologist. So, some note so that when the
Yeah.
radiation oncologist looks at it, he at least has a view of what you are thinking about.
Correct. Correct. What my plan is
It's a
something like that.
it's a very fair suggestion, sir. Thank you so much for sharing this. We'll work on this and we'll build it for sure. I hear you completely. Thank you. Dr. Ayushi, thank you very much for your feedback. Really grateful. The issue is there is usually a lag in obtaining answers. I think that's a very fair feedback, Dr. Ayushi. I think the app is slower than what we would like it to be. Let me help you understand what happens behind the scenes, right? Why we are not as fast as some of the other ones. I think as compared to, for example, the generic chat GPTs of the world, I think the key difference is because the benchmark that of accuracy we've set for ourselves is 97%. So what happens is we generate the answer, then we revalidate the answer, okay, and then we add the citations to it. So every answer that you get actually goes through these three-stage filtration process or revalidation process before it comes over to you. And I think that therefore ends up consuming a lot more time and very honestly money and resources from our end as well. I think it's a very fair feedback, Dr. Tyagi. Our team is working on it even right now. We'll try to improve it much more significantly. The next release will have a significantly shorter time. But thank you so much for this feedback.
Good evening, sir. Dr. Manjeet, sir. So you asked for expert suggestions in one page like that. So updates and reviews like that. So Haneesh, can you please go to the Discover section?
Yes.
Yeah. Sir, here we are providing the latest articles. Those are published in the Nature and the few more renowned journals. So this covers everything. May I know any that customized that you are looking for, sir?
In recommendation section or whenever we are recommending something, then the source of like it is from NCCN guideline, it is from ESMO, ASCO,
Mm,
or from some trial
mm,
like that, or by some article by some expert.
mm,
I
Okay, sir.
hope whenever if we are putting a question or a query and when it is answering, then I think it has been trained on ESMO and
Yes.
our
Yes.
NCCN guidelines.
correct.
But if we can integrate or we can train it on that also, then it will be helpful basically. In maybe in some cases when a case is slightly complex, not the
Yeah,
routine case.
yeah, yeah.
Okay, sir.
Dr. Manjeet, let us call you separately maybe tomorrow. We'll get a little deeper into what can help you
Yes.
more. है ना? Thank you, sir.
Thank you so much, sir.
Thank you, sir.
Okay. What else, doctors? Very curious to hear your POV, your points. Okay. If not, what I'll ask Dr. Haneesh to do is bring on the screen the newer features that we are experimenting with right now. And we'll talk a little bit more about that. Dr. Haneesh, can we bring that up? Right now our team is piloting three new features. Okay. The first one is clinical trials. So if you upload, let's say, a file or let's say some biomarkers, then basis that particular patient's unique demographics, unique biomarkers, and other markers, are we able to identify the clinical trials that suit that particular patient? So that is one feature that we are working on. The second one, which I personally enjoy a lot, is called clinical twin, which is once again basis these biomarkers. Can I, in the entire history sheet, be able to identify an equivalent twin, a patient who's had same therapy and what was their progression in this particular journey? So you start getting real world evidence through this particular platform. And last but not the least is AI safety checker. Uh, I'm sure all of you experience this every day. And in fact, this was feedback that one of the senior doctors from TMC only gave us. You know, you write a prescription or you write a certain line of therapy, and the first thing the patient will do is he will take a screenshot and like upload it to ChatGPT. So, can you do something which can help us check, like put an AI check before we hand over anything to a patient so that there's no nuisance value around it, right? And that's something that we are building on. What the strength that we have is we've already integrated all the medical information into our platform, into our language model. And we are going to now run safety checks on top of it so that you are able to elevate the prescription. In one of the trials that we did, with oncologists that had over 100 consultations, the quality of the prescription went up by almost every treating physician. And some of these were minor edits, some of these were major edits, but everybody elevated the prescription at least by one element as compared to what they had written originally. So AI safety checker is another very interesting feature that we are building. Let me now invite all of you once again. What could be some other features that we could build up? I already have one feature which is integrated with some other data sources. I have made a note of that, Doctor. From Dr. Tyagi, I also have a feedback around time. So I'll work upon that as well. What else can help us? Excellent. I know it's late in the evening. It's almost 8 plus now, so we'll bring this to a closure. You all have my email ID and my WhatsApp number. I would love for you to message me. I would love for you to email me. And I will personally respond to it. We will work to make sure that we are able to make a product that brings in evidence-based therapy, helps you free up some of your time, and in the process also improve patient care. Dr. Tyagi, I have your message with me. Uh, very fair point. I think this is something that we should be working upon. I agree with you. We'll work upon this, Dr. Tyagi. Good point. Any other messages that you'd like to leave for us? Please use the chat box. Very happy to power this in the chat box. Please speak up to me. Very happy to engage on that as well. Great. Thank you, everybody. It's been fantastic knowing you. This is Vivek Slaria and Dr. Haneesh from OneRx team, and wish you all a fantastic evening ahead. Bye-bye.